Hello, this is a video lesson on positioning of the digestive system. There are technical considerations we're going to take with regard to the digestive system that include the GI transit, examination procedure, contrast media, preparation of the exam room, exposure time, radiation protection, which we should always protect our patient unless we're imaging the abdomen or hip or pelvis, and then SID is going to be 40-inch SID for all exams of the digestive system. So as far as the GI transit, we have to consider peristalsis, which is the wave life motions. The contractions are 3 or 4 waves per minute that occur in the filled stomach. The averaging emptying time of the stomach is 2 to 3 hours. The first part of the barium meal reaches the ileocecal valve in 2 to 3 hours. The last part reaches the ileocecal valve in 4 to 5 hours. So the barium usually reaches the rectum within 24 hours, by the way. So when to prepare the room, the equipment, and the contrast prior to the patient's arrival, prepare the patient for the procedure, in all cases, artifact removal, gowning, and explanation, obtain and record the patient history, obtain a scout image if that's the protocol for the facility, communicate with and assist the patient, assist the radiologist during the procedures needed, and take overhead images as required. So compression includes a compression cone, which can be directly on the equipment, a pneumatic compression paddle, which is what I was just showing you in the previous slide, or an F spoon is another option. And those are just different options that that radiologists have. Prior to the patient entering the room, we want to adjust the equipment controls to the appropriate settings. We wanted to have the footboard and shoulder support available. Check for proper operation of the imaging and the recording devices. Prepare the type and the amount of contrast media and make appropriate image markers available. Prior to the procedure, communicate with the patient about explain the type and the administration route of the contrast. Use layman's terms. Explain the taste and the texture, such as the chalky taste and the thickness for the barium and bitter for iodinated agents. For an enema exam, show the tube tip, explain the insertion, describe the abdominal sensations with the flow of contrast into the colon. Point out that the lights are dimmed and explain why. The radiologist will instruct you on how to get the patient into the position and how to breathe, and will assure the patient that you will assist them as needed as well. If radiology images are obtained, like I said, just overheads, you're going to inform the patient the approximate number of images you'll be taking when the radiologist leaves the room. After you verify the patient understands the overall procedure, introduce the patient and the radiologist. Exposure time. The challenge is to eliminate motions. The shorter exposure time is necessary in areas of faster movement. So based upon each region, peristalsis is greatest in the stomach and the duodenum, and it slows in the distal part. Peristalsis is affected by body habitus, pathology, use of narcotic pain medicine, body position, and respiration. The modified barium sol is one of the most common imaging procedures to the soft palate, the pharynx, and the larynx. It's a modality of choice to demonstrate the structure and function of the anatomy of deglutition and evaluate the presence of the abnormalities, especially aspiration. The technical considerations is that the imaging and the recording of deglutition must occur at 30 frames per second, and it can be stationary equipment or a room equipped with a mobile C-arm. This one's just stationary equipment. We've got a specialized chair that facilitates consistent, safe, and comfortable upright position, and your contrast agent of choice is barium sulfate. For the lateral projection, the patient is seated or standing in a true lateral position with the mid-coronal plane perpendicular to the image receptor. We're going to depress the shoulders and ask them to lie in the same transverse plane. You're going to assist the speech pathologist in adjusting the patient's head and mobilize the head by having the patient look at an object in line with the visual axis. The speech therapist usually dictates alignment of the chin. Our central ray is going to be perpendicular to the image receptor. Our collimation is going to be adjusted so that the radiation fields the level of the EAM to the jugular notch. And our structures shown are profile images of the contrast-filled mouth, pharynx, and cervical esophagus. The lateral projection best visualizes proper functioning of the epiglottis. This is an important thing to note. We're to be looking at the lateral projection evaluation criteria. We want to see all pharyngolaryngeal structures, the area from the nasopharynx to the upper part of the lungs in preliminary studies, and no superimposition of the trachea by the shoulders. The AP projection may be performed, but not always. In this case, you would turn the chair the patient facing the other direction, and the patient would still be upright or seated in the positioning chair or the footboard, standing on the footboard. If the standing position is used, have the patient distribute the weight of the body on both feet. Center the mid-sagittal plane to the midline of the image receptor. Adjust the patient's shoulders to line the same plane to avoid rotation. You're going to assist the speech therapist in the specific head position to evaluate deglutition. We're going to center our central way perpendicular to the laryngeal prominence. We're going to adjust the radiation field to the level of the EAM to the jugular notch and 1 inch beyond on the skin edges on the sides. So this image is going to show a contrast-filled mouth, pharynx, and cervical esophagus in images and used to evaluate unilateral abnormalities. On the AP projection, we're going to see all of the soft tissue pharyngolaryngeal structures in the area from the nasopharynx to the uppermost part of the lungs without rotation. For the esophagus, which is a procedure performed without the speech pathologist, it's just the radiologist and the radiographer, there's no patient prep. We may use single or double contrast. With single would be barium sulfate or water-soluble iodine, and for double it would be barium sulfate and water dioxide crystals. The first part of the exam is fluoroscopy, which is just swallowing, and the purpose is to show intrinsic lesions and extrinsic pathology pressing on the esophagus. And the role of the goal of the patient is to keep drinking to fill the esophagus. The next several slides are about overhead projections, which would be after the radiologist leaves the room and they want certain projections performed. So first we have the AP or PA we'll talk about. Secondly, we'll have the RA or LAO with a 35 to 40 degree obliquity used to get a wider space for an unobstructed image of the esophagus between the vertebra and the heart. And then we have third, the right or the left lateral. Recumbent positioning is used to obtain more complete contrast filling of the esophagus. So starting off with the AP or PA projection of the esophagus, our patient is going to be prone or supine. We're going to center the mid-sagittal plane to the image receptor, and we're going to turn their head slightly to facilitate drinking the contrast. We're going to be perpendicular to the midpoint of the image receptor at the level T5, T6. And unless we need the Valsalva maneuver or have other type of issues, we're going to ask the patient just to swallow several mouthfuls of barium in several succession and then hold a mouthful until immediately before the exposure. The structures shown are the contrast-filled esophagus from the lower neck to the esophagogastric junction. So in general, we're going to have general items that we're going to need for the esophagus, and that's the esophagus from the lower portion of the neck to its entrance into the stomach. We want an esophagus filled with barium, and we want to see penetration of the barium. Something very specific with the AP or PA projection is the esophagus is going to be seen through the superimposed thoracic vertebra, which we can see here in this image. And plus, there should be no rotation of the patient. On the AP or PA oblique projection of the esophagus, we could perform an RAO, an LAO, or even an LPO. But in this case, the mid-sagittal plane forms a 35 to 40 degree angle with the image receptor. With the RAO, which is the most common of the three obliques, we're going to have the right arm down at the side, the left arm up by the head, and we would reverse that for the LAO. We're going to center the elevated side to the image receptor through a plane 2 inches lateral to the mid-sagittal plane. We're going to center at the same location as we did for the AP or PA. We're going to have the same barium administration and respiration instructions and the same structures shown as the AP and PA projections. So the only extra thing we need to add for our evaluation criteria is we have an esophagus between the vertebra and the heart. On the left is the RAO position, and on the right we've got the LPO position. On the lateral projection, we want to have the patient's arms forward and the mid-coronal plane centered to the image receptor. But on everything else, we're going to have the same central ray, the same barium administration, and the same structure shown as we did for the other two images of the esophagus. And this is our last part. We're just noticing here that we're going to miss the shoulders. That's the one thing we're going to, the esophagus is over the shoulders in this case. But we do see that the proximal esophagus without the superimposition of the patient's arm though, and the ribs to be posterior to the vertebra superimposed to show the patient was not rotated. On the upper GI series, the purpose is to evaluate the distal esophagus, the stomach, or some or all a part of the small intestine. For contrast media, for single contrast, it includes barium sulfate. Now the thing is, if a patient has a perforation, we would use water-soluble iodine. On the other hand, we could perform a double contrast study that includes high-density barium and gas-producing substance like powder, crystals, pills, or carbonated beverages. And the double contrast will visualize small lesions in the mucosal lining of the stomach. The biphasic exam is a combination of the single and double contrast methods during the same procedure. So for patient prep, the patient should be NPO for 8 to 9 hours before the exam and not smoke or chew gum. We may perform an AP scout before the fluoroscopic study. Then we'll do the fluoroscopic portion, and then we're going to have the small intestine study consisting of images at frequent intervals using passage of contrast, possibly after this exam. So then we're going to usually begin with the patient in an upright position if possible. The radiologist instructs the patient to drink 2 or 3 mouthfuls of barium. The esophagus is examined with 2 or 3 swallows. Manual manipulations used to coat the gastric mucosa, and the patient drinks more barium to fill the stomach. The exam determines the size, the shape, and the position of the stomach, examines the contour of the stomach during the peristalsis, observes the filling and emptying of the duodenal bulb, and detects abnormal function or contour of the esophagus, stomach, and duodenum. Now we're going to look at the overhead images that can be performed after the radiologist leaves the room from the fluoroscopic portion of the procedure. We can perform an AP or PA scout, of course, that would be before the exam even begins, but there's a PA, an AP, an RAO, an LPO, and then the right lateral. So the AP or PA scout image is used to delineate the liver, the spleen, the kidneys, the psoas muscles, the bony structures, detect any abdominal or pelvic calcification or tumor masses. On the PA projection of the stomach, this is after barium was introduced, the patient is prone. Upright could be used to show the relative position of the stomach. We're going to align midline of the grid to the sagittal plane, halfway between the vertebral column and the left border of the abdomen. With the patient prone, we're going to center 1 to 2 inches above the lower rib margin at the level of L1, L2. If the patient is upright, we'll center 3 to 6 inches lower than L1, L2 since the stomach would be lower with the patient standing. We're going to perform respiration at the end of expiration, and we're going to center to the perpendicular. Our collimation is 10 by 12 on smaller patients or 11 by 14 on larger. And the PA projection is going to show the contour of the barium-filled stomach and the duodenal bulb. The pyloric canal and duodenal bulb are well shown in patients with an asthenic or hyposthenic habitus. So this is important here, looking at different body habitus, looking at what positions would show what best. This is the PA projection of the stomach. We're looking at the barium. It's located in the fundus on this image. The fundus is at this point is in its highest position due to since the patient is prone. We see the entire stomach and duodenal loop. The stomach is centered at the level of the pylorus. There's no rotation of the patient, and we have penetration of the contrast medium. This is the position showing the different body habitus, looking at hyperstenic, hypostenic, astenic, and stenic patients. And so just looking at the difference in the positions of the stomach and how it does vary. On the AP projection of the stomach, we're going to perform this with the patient supine. For a 14 by 17 exposure field, which would be for the stomach and the small bowel, you would center to the midline of the body. If the protocol is that you use a 10 by 12, which is just for the stomach, then you would center midway between the midline and the left lateral margin of the body. You want to center midway between the xiphoid process and the lower rib margin, which is L1, L2. You want to suspend at the end of expiration, and you want to center perpendicular to the image receptor. So the two collimation field sizes would be a 10 by 12, as mentioned for the stomach, and 14 by 17 for the stomach and the small bowel. Now, something that's important is the fundus is now filled with barium. If the patient is supine, the stomach's in its lowest position in the body. It's kind of positioned like this. So the fundus is low, so now it's going to be filled with barium. And so we're going to see a double contrast delineation of the body, the pyloric portion, and the duodenum. Because of the elevation and superior displacement of the stomach, this position affords the best AP projection of the retrogastric portion of the duodenum and the jejunum. And so something else, an AP projection of that abdominal thoracic region shows the organ or organs involved in location and extent of any great gross hernial protrusion through the diaphragm. So you can see in the image shown here that the fundus of the stomach is filled with barium, as we talked about. We want to see the entire stomach in the duodenal loop. We want to see the double contrast visualization of the gastric body, pylorus, the duodenal bulb. We want to see the retrogastric portion of the duodenum and jejunum. And with this image, we're looking at a 14 by 17 exposure field, but you'll see the diaphragmatic hernias possibly too. The stomach would be centered at the level of the pylorus in 10 by 12 images. There should be no rotation, and we should see penetration of the contrast and also see surrounding soft tissues. Here are two images showing the PA and the AP projections. The PA projection is on the left-hand side, showing that the patient has air in the fundus. So there's air in the fundus. In the AP projection, because the patient is supine, and when the patient is supine, the fundus is at its lowest level. So now the fundus has barium in it. The PA oblique projection we're going to perform it is with an REO position. We're going to have the right arm down by the patient's side, support the body on the left arm, and flex the left knee. We're going to center 1 to 2 inches above the lower rib margin at the level of L1, L2, and we've got a pretty big degree of obliquity difference here, 40 to 70 degree oblique. It's according to what we need to get the best view of the pyloric canal and the duodenum. So for example, the hypersthenic patient requires more obliquity than the sthenic or the asthenic. So 40 would be more for the asthenic, 70 would be more for the hypersthenic. We want to suspend at the end of expiration, and we want to center perpendicular to the center of the image receptor. We want to use a 10 by 12 on a smaller field size by a smaller patient, or 11 by 14 for the larger patient. And we want the entire stomach and duodenal bulb loop demonstrated. Something very important, it visualizes the best image of the pyloric canal and the duodenal bulb in sthenic patients. The gastric peristalsis, by the way, something to note, is much more active in this REO position. So you want to be careful and have very short exposure times on this one too. So looking at the image, we do see air in the fundus because the patient's back in a PA oblique projection. So there's air in the fundus. We want to see the entire stomach of the duodenal loop. There's no superimposition that pylorus or duodenal loop bulb. The duodenal bulb and the loop are in profile, so there's the bulb here. The stomach is centered to level the pylorus, and we can see penetration of the contrast medium, and we can see surrounding anatomy. On the AP oblique projection of the stomach, we're going to perform an LPO. We're going to abduct the left arm and place the hand near the head and place the right arm along the side of the body or behind the body or across the chest, just out of the way. Flex the right knee and elevate the knee toward the left. Place a sponge behind the patient's back for support. Center midway between the xiphoid process and the lower margin of the ribs. And we should use a 45-degree oblique for the stomach patient. Angle can vary from 30 to 60, with 60 being for the hypersthenic patient. We want to suspend at the end of expiration, and we want to direct our beam perpendicular to the center of the image receptor. Our collimation can be 10 by 12 in smaller patients or 11 by 14 in larger patients. And we're going to see the fundus portion of the stomach. Because of the effect of gravity, the pyloric canal and the duodenal bulb are not as filled with barium as they are in the RAO positioned. So here we are, when the patient is in an AP oblique, just like the AP projection, your fundus is filled with barium. So always on AP and AP obliques, we have barium in the fundus. So we're going to see the entire stomach in the duodenal loop. We'll see the fundic portion of the stomach. No superimposition of the pylorus duodenal bulb. The body of the stomach is centered to the image. We want to see penetration of the contrast medium, and we want to see surrounding anatomy. The body and the pyloric antrum should be shown with double contrast visualization. Here's an image of the RAO and the LPO. In the RAO, which is on the left-hand side, it's a PA oblique projection, so we're going to see air in the fundus. This person has an ulcer, by the way. On the right-hand side, this is the LPO, which is an AP oblique, and so we see barium in the fundus. Just looking at the two images. The right lateral projection of the stomach is where the patient is in a lateral recumbent. We're going to adjust the patient so that the plane passes midway between the midcoronal plane and the anterior surface of the abdomen coincides with the midline of the grid. We're going to center at the level of L1, L2 when the patient is recumbent, or L3 if the patient is upright. We want a true lateral projection position. So we want to suspend at the end of expiration and direct your beam perpendicular to the center of the image receptor. We're going to do the same thing with our collimation, 10 by 12 in smaller patients, 11 by 14 on larger. So we're going to see now our anterior and posterior aspects of the stomach, the pyloric canal, and the duodenal bulb. The right lateral shows the best image of the pyloric canal and duodenal bulb in the hypersthenic patient. So that's another position for looking at the duodenal bulb and the pyloric canal. So we're looking here at the side view, looking at the anterior aspect and the posterior aspects of the stomach. And then we're going to see the entire stomach in the duodenal loop. We'll see no rotation of the patient. We're going to see the stomach centered at the level of the pylorus. We're going to see penetration of the contrast medium, and we will see surrounding anatomy. Now, patient prep for the small intestine or small bowel series. Orally is the most common method by reflux filling with a barium enema, which is uncommon, and there's also enterocolysis, which is direct injection via an intestinal tube placed in the small bowel. We're going to focus on the oral method, which is the most common. For GI transit, we're going to have a soft or low residue diet for 2 days before the exam, MPO after the evening meal of the day before the exam, and a cleansing enema can be administered to clear the colon. The bladder should be empty to avoid displacing or compressing the ileum. In the small bowel series, which is called that, is because there are several images taken at timed intervals. Each image is identified with a time marker indicating interval since the ingestion of barium. Images are taken with the patient supine or prone, depending upon the protocol at that facility. Supine's used to take advantage of the superior and lateral shift of the stomach, which improves visualization of the duodenum and jejunum and prevent compression of overlapping loops of the intestine. The prone is used to compress abdominal contents and enhance image quality. So for the oral method of examination, we're going to do a PA scalp image. The radiologist performs fluoroscopy. The first image is usually taken within 15 minutes after the patient drinks barium. The next interval varies between 15 to 30 minutes, and it's usually completed in 30 to 60 minutes. Many times the patient we have to use the compression paddle to visualize the ileocecal valve. The radiologist inspects each image, and the procedure varies upon the individual. For a patient with hypomobility, after 3 to 4 hours of administering barium sulfate, radiologists may want to accelerate the peristalsis with one of three ways. Once with a glass of ice water or other routinely used food stimulant, water-soluble iodinated contrast agent, or tea or coffee, or can administer a peristaltic stimulant every 15 minutes through the transit time. So the registry suggests that we do a PA projection, even though the image shown in Merrill's is AP. So the patient would be prone. We would want the mid-sagittal plane centered to the image receptor. We want to suspend at the end of expiration, and images taken within 30 minutes are taken at the level perpendicular to the level of L2. Be careful with that. Delayed images, which are those 30 minutes and later, are taken at the level of the iliac crest. We are going to open our collimation to 14 by 17 for all these projections. And we're going to have a small bowel progressively filling until the barium reaches the ileocecal valve. And so the evaluation criteria is we want to see the entire small intestine on each image, the stomach images on initial images. We want to see a time marker. We want the vertebral column centered on the image. You want no rotation of the patient, penetration of the contrast medium, and a complete examination when the barium reaches the cecum. So here's an example of a small bowel follow-through where we have the immediate image taken, a 15, a 30, and then a 60 on the same patient. And we do use time markers. The final part of the small bowel are the ileocecal spots. So something that happens is either the radiologist or the radiographer will use the compression paddle or an F-spoon, and they're going to compress the area so we can see the ileocecal valve more clearly on the image. And so you can see that there were 4 images taken of the ileocecal valve in this case. This concludes our lesson of the first part of the procedures of the digestive system.